Hi, everyone. Good morning, afternoon, evening. I think we have covered all time zones in this flyer here. Thank you for joining us today for this webinar on health financing. And thank you for joining us with the date change. I know we will have some colleagues trickling in, but given the amount of information that will be shared today, perhaps we can just get started and have our colleagues find us. We will be recording this call for our notes, but also to publish on our website and share as a resource. So thank you for joining. We know it's a really busy time for GFAN Africa, for GFAN Asia Pacific, for our colleagues working in countries preparing the GCH funding request and going through some of those difficult negotiation processes in a context where we have we are seeing reduced allocations. We are seeing growing pressures on health financing systems, the bilateral agreements that are being discussed, negotiated in many countries in Africa, as well as generally a sense of fatigue talking about budget with government representatives. So we are hearing that from so many sides, and it's really great to come together in a space like this because so often health financing and budget advocacy is kept away as a technical discussion that only a few people have access to. So being able to broaden that and encourage all of our capacity building in this space is really valuable. So thank you to MSF and GFAN for bringing this to us. Today, we are joined by an expert, Nuria Brixi, who is a health financing and health policy expert who is with the London School of Tropical Medicine and Hygiene, London School of Hygiene and Tropical Medicine. I knew there was something wrong with that. And Nuria will walk us through some core concepts in health financing, what is realistic when we talk about DRM, and where we can strengthen our engagement as civil society, where we can strengthen our engagement as global fund advocates. And Nuria, really grateful to have you here to be sharing your expertise with us. Thank you so much for being with us today. And we are looking forward to hearing your presentation and then hear from our colleagues at MSF, our partners at MSF, about health financing and how we can strengthen our engagement and create some smart advocacy for fair financing. So thank you. And with that, I'll pass it to Nuria.
Thank you so much. I am delighted to be with you. I'm just sharing my screen now. I hope you can see it. Yes. I'm just going to make it present to you. Okay. Well, thank you very much for giving me the floor and for giving me an opportunity to talk about something that I am indeed very passionate about. I've been working on health financing issues for a bit more than 20 years, and something that I think is really important for advocates to understand are the core concepts of health financing. So today, what I am going to highlight to you is what health financing is, particularly what domestic resource mobilization is, and why at a time when we increasingly hear about co-financing and the need for co-financing, relying so exclusively on domestic resource mobilization in such a short term might not be as easy as it sounds. For context, we all know that there's been a lot of aid disruption in the past couple of years. We project about 20% fall in aid in 2026, but it might be even worse. And this has real life consequences in that some projections have already talked about more than an additional 9 million deaths by 2030 as a result of these cuts. So it's an incredibly important moment for us to think about the alternative solutions to aid and what is or is not feasible. You know this already, that indeed the aid disruption that we are encountering are the most severe we've seen in a generation. US aid has disappeared, but Other donors have also dramatically decreased the aid that they're allocating. The UK, for example, where I'm sitting at the moment, is going to be allocating about 0.3% of its GDP to health. And even that is not really all for low and middle income countries. And some regions of the world, such as sub-Saharan Africa, are going to be suffering particularly. And this has a very real impact on the diseases that the Global Fund is meant to be supporting. The Global Fund, in its response, has put emphasis on transitioning away from aid towards domestic resource mobilization. And some countries will receive much less than others. There's a differentiation in terms of income groups as to how much countries will be affected. And as a result, there's also a differentiation in the way in which the different income groups will need to respond. But you know all this. I'm not going to be telling you anything more on the Global Fund response. This is maybe something that Tess will be able to cover when we talk specifically about the response of civil society. So really what I'm going to be focusing on today is health financing, what it is and what we know globally can be realistic responses to the decrease in aid. The first thing to say is that when we talk about health financing, we're really talking about three core functions. And globally, we have a tendency to only focus on the first, which is revenue raising, or otherwise called revenue mobilization. This revenue raising, it's really just about how we are going to be raising and mobilizing funds for health. Countries have a number of options to them at the moment. They can raise additional taxes, and I'll talk about the various taxes that exist. They can focus on increasing the insurance coverage, and I will talk about that further. They can get donor grants, but as we know, we're in this situation and we're having this conversation because donor grants are decreasing. And they can also ask for out-of-pocket payments. This is revenue mobilization in general. When we talk about domestic resource mobilization, we're just talking about the domestic public funds that can be raised through either additional taxation or through more broadly public revenues. Domestic resource mobilization does not include donor aid by definition. It's just about the domestic resources that can be raised. And it's very important to point out that it does not include out-of-pocket payments. We know that out-of-pocket payments have an extremely negative impact on people's ability to seek care. So there's decades worth of evidence as to their negative impact on access to care. But there's also decades worth of evidence on the fact that it is a very inefficient way of raising resources. So when we talk about domestic resource mobilization, we're really talking about taxation and public revenues. Insurance is considered a type of taxation because it's a tax on employment. So I include insurance in the question of taxation. So that's the first function of financing. The second function of financing is what we call pooling. It is once we've raised all the different revenues, taxation or public revenues or insurance, our capacity to bring all those resources together. And this is a key function of financing because it is the function that supports financial protection. And it supports financial protection because when you bring all the resources together onto one pool, you facilitate the cross-subsidization between rich and poor people, between healthy and sick people. If you don't bring the resources together, you're not going to facilitate cross-subsidization and you're not going to progress in financial protection. The third function of financing is purchasing. So it's once you've brought all the resources together onto a pool, what are you going to do with these resources? How will you buy the services? What services will you buy? And from whom will you buy the services? So purchasing is really all of these questions of what is the benefit package that you want to put your resources towards? Will you be only purchasing services from the public sector? And at what level? Is it only primary healthcare? Is it also secondary and tertiary care? Or will you also be purchasing services from the private sector? And the private sector can be the for-profit private sector or the not-for-profit private sector. And then how are you going to be paying for those services? What kind of provider payment mechanism will you use? Will you do a simple reimbursement, also called fee-for-service? Will you be providing the resources beforehand, giving a small budget to the facility, something that we call, for example, capitation? So there's all sorts of options around provider payment mechanisms that each have plus and minuses. And if you have questions around that, I can talk some more about it. But really, the key message here is when you are engaging in health financing discussions, you should not just be engaging on discussions around how to raise revenue, but you should also be thinking about how you're going to be pulling the resources together and what purchasing mechanism you will be using. There's other key concepts when you talk about health financing that you'll hear about a lot. The first that you will consistently hear about is universal health coverage, is the cube on the left-hand side. Health financing helps in progressing towards universal health coverage in multiple ways. When we talk about UHC, the UHC cube, we're talking about 3 dimensions. Before I was talking about 3 core functions of financing: revenue mobilization, pooling and purchasing. When it comes to the cube, we're talking about 3 dimensions. The first dimension is who are the people that you want to be covering? Who are you protecting in your drive towards universal health coverage? Are you going to be starting with the formal sector, with the better off, which is very often what we see in most of our countries? Or are you going to be starting with the most vulnerable, those who are least able to contribute in any way? That's a question that the first dimension of the cube helps you think about. And that is a dimension that is very much relating to the purchasing function. You remember that I was saying, who are you buying for and what are you buying? The second dimension of financing is the UHC cube, is what services will you be covering? So this is about the benefit package. Are you going to be selecting a benefit package that covers services that the most vulnerable need? Or will you cover services, for example, just at hospital or tertiary level for those in the urban sector who are able to afford them? So you need to spend a lot of time thinking about your benefit package. And this again relates to the question of purchasing. And finally, the third dimension of the UHC cube is financial protection. So what do people have to pay out of pocket? Where are the resources going to come from? If the way in which you raise your resources, so the first function of financing, mobilization, is fully out of pocket, you're not going to be providing financial protection. So you need to move to a system of mobilizing resources that detaches the episode of ill health with the payment, which is why we say that when we think about financial protection and the ways in which we can raise resources, it's very important that the resources have a prepayment aspect to them, that we dissociate being ill with having to pay. You don't want people, when they're sick, to have to ask themselves, do I have the 30 cents or the $3 in my pocket to pay? You want the payment to happen independently from the episode of ill health. So this UHC cube is very important when we talk about financing. And at the core of this cube is a concept that is called progressive universalism. Progressive universalism just means that we need to start with the worse off. Ultimately, when we progress towards universal health coverage, we can do it in all sorts of ways. We could start with covering the better off, and we could start with covering the services only for the better off, and it can all be out of pocket. That's progressing towards universal health coverage, but it is not respecting the concept of progressive universalism. So for us, when we progress towards universal health coverage, with progressive universalism at its core, it means we start with the worse off, we start with the services for those worse off people, and we make sure that out of pocket is as limited as possible. The drawing on the right-hand side is just saying that it's very complicated to progress. Another concept that is really important for you is public finance management. Quite a lot of you in the survey have said that you want to understand better what it is. So public finance management is simply the rules and regulations that govern the way in which public resources are allocated, are spent, and are monitored. And it very much aligns with what we call the budget cycle, which you see here on the right-hand side. The budget cycle is how the budget is formulated, what are the budget lines, how much money will you need for delivering, for example, your National Health Strategic Plan, how the budget is executed, where is the money going? Are we spending all of the money that the government has allocated, or are we not able to do so? And it's very important for you as civil society to particularly understand the budget formulation and the budget execution, because you may ask for more money, but the Ministry of Finance might very well tell you, well, I've allocated 1 million, you've spent 500,000, why should I give you more? So it's very important for you as civil society to understand where the budget execution blockages lie. And very often the budget execution issues lie with public finance management systems that are within the remit of Ministry of Finance, not Ministry of Health. And then the last bit of the budget cycle is the budget monitoring, which again is really important for you as civil society to understand, because you need to be able to hold decision makers to account and see whether the public spending has happened where it was meant to happen. What the international evidence says in relation to the three functions of financing is first and foremost that if we want to be progressing towards universal health coverage, we need public resources. They are essential. And the graph on the right-hand side just shows that the more governments spend on health, the more progress we make on UHC. However, the evidence also shows that out-of-pocket payments remain the primary source of financing across low and middle-income countries. And this graph just shows the proportion in orange of out-of-pocket that continue to dominate despite the fact that we have evidence of how bad they are. And this slide is really just about re-emphasizing the fact that out-of-pocket payment and the reduction of out-of-pocket payment is a non-negotiable for us as advocates and civil society working in health financing. The evidence also shows that when it comes to pooling, we can't have fragmentation, which is dominant across most low and middle income countries, in no small part due to donors having vertical approaches, saying, this is my disease, I am focusing on this disease, and I'm not going through government systems. So trying as much as possible to pool resources together is very important. Obviously, there are limitations to this. There are countries that don't have functioning public finance management systems, that don't have a mechanism that donors are either able to use or trust. And in those cases, often donors put together what we call health basket funds, or what we used to call sector-wide approaches, which is a pooling of donor funds that is not on budget. But over time, ideally, if the government is able and willing to protect all of its population, including discriminated against populations, then the evidence shows that it's best to pool all of the resources together. And when it comes to purchasing, what we know is that at the moment, there is a lot of purchasing that is passive. Passive means that the purchaser, whether it's the donor or whether it's the government, are not defining the quality, they're not defining the prices. They are price takers and quality takers. So it's very important to move towards what we call strategic purchasing, which is where we make sure that the purchaser is able to define what should be bought, the quality of the care that should be bought, who they should buy from, through, for example, contracting arrangements, and making sure that the provider payment mechanisms are adequate and incentivize the right behavior. So that's what we see at the global level. Now, as to the question of transitioning away, so this was all about what health financing is and what we know at global level, what is the accepted norm at this stage at global level. Now, coming back to the question of co-financing and transitioning away from donor funding, it's very important to understand what realistically we can expect from countries. And the evidence is quite clear that, yes, of course, it is the responsibility of governments to pay for healthcare. But some countries are in a situation that is either economically extremely unfavorable, or don't have the technical capacity from one day to the next to put in place the systems that would allow them to raise a lot of additional domestic resources. There's various solutions out there. The first solution that we talk a lot about is general taxation. This is undoubtedly the most sustainable way of raising additional domestic resources. And if we look at the graph on the left-hand side, we see that, and sorry, these are just a few countries, there's a lot more, but my graph only captured those for some reason. And I appreciate that a lot of you are from Asia, so this might not be relevant to you. But generally, the tax to GDP ratio, i.e. the amount of tax that countries in low and middle income countries are raising, is very limited. So there is a lot of scope to work on the breadth and the depth of tax reforms in countries. Even before that, I didn't put it on the slide. Obviously, if countries grow economically, this is going to be the best way to increase the overall envelope. Economic growth is undoubtedly the best way to increase the resources allocated to health. It's very difficult for us in the health sector, however, to engage with questions of economic growth, other than to say that unless the population is healthy, you're not going to be able to have economic growth. So that, from an advocacy perspective, is a very important point. Coming back then to general taxation, it's also very difficult for us as health to be talking to ministries of finance and tell them what it is that they should or shouldn't do in relation to taxation broadly. And I have been in many discussions with ministries of finance, and they always push back. So a lot of the health advocates and the health academic literature has therefore focused on taxes that are specific on products that are harmful to health. We used to call them sin taxes. Nowadays, we call them health taxes. And these are taxes on alcohol, on tobacco, on sugar-sweetened beverages, on CO2 emissions. And it's much easier for health people to go to ministries of finance and say, unless you tax these products, we, the health sector, will continue to have to bear the brunt of the consequences of people consuming these products. So these taxes have a dual benefit of reducing the demand, but also being much more politically acceptable from the population perspective and in terms of your interaction with the Ministry of Finance. The problem with these taxes is that the revenue that they raise is actually relatively limited. A maximum of 0.5% of GDP can be raised if a multiplicity of those taxes are put in place. So they shouldn't be seen as the solution, but they can be seen as part of a solution, and certainly as a way to start engaging the Ministry of Finance and the population around the need for additional resources for health. Another solution that is often talked about is social health insurance, and we see that in many Asian countries and in many countries across Africa. So the positive about social health insurance is that it does detach the experience of ill health with the payment. So there is a prepayment, and that's a good thing. And it does contribute to pooling and to risk sharing, depending on how social health insurance is done. The problem, though, with social health insurance is that it tends to be a lot easier to start with the formal sector because social health insurance, at the end of the day, is a tax on employment. And you know how much people earn in the formal sector. You don't really know what people earn in the informal sector. And in many of our countries, the informal sector is actually dominant. In many African countries, the informal sector is about 90% of the population or of the working population. So it means that social health insurance hasn't managed to progress very much generally across low and middle income countries. There are some exceptions, but generally it's not an, a short-term solution, let's say. It can contribute to progressing towards greater pooling and better purchasing, and certainly towards cross-subsidization and better financial protection, but it will take time. It's an expensive system to set up, and it needs to be seen in collaboration with general taxation reform and health taxation reform, which is why nowadays in many countries we talk about hybrid models that bring together the taxation and the social health insurance. Another solution is debt relief. And if we look at, again, the debt to GDP ratio across sub-Saharan African countries, it's high. Some countries not so high, and it's all a question of what you consider to be an acceptable level of debt. There's a big push for debt relief, particularly as a response to COVID. A lot of low and middle income countries entered a debt spiral that is putting a lot of burden on fiscal space for those countries. And there's a lot of discussion in debt to health swaps. Great, definitely debt relief is important. Be careful when you talk about debt to health swaps. The devil is in the detail. And often what it means is not debt relief, is a consolidation of all the debt that exists with a better interest rate, sorry. And the saving done by consolidating all the debts is then what would be the debt relief. So just be mindful when you engage in debt to health swaps that indeed the devil is in the detail. The last point to say in terms of the potential to create fiscal space is efficiency. We know that a lot of resources are wasted across our health systems, and a 2001 report, WHO report, talked of about 40% of resources being wasted. We all have plenty of evidence, and there is literature on indeed this issue of lack of efficiency of spending. But again, this is complicated because it's often the inefficiencies are related to either political settlements that benefit from the inefficiencies or the technical complexities that are very difficult to address. So yes, we can spend our money better, undoubtedly, but to address the sources of inefficiencies is not something that happens overnight. So really what I want to bring out to our attention is that the evidence is telling us that yes, we can find additional domestic resources. Yes, we need to focus on taxation, social health insurance, health taxes. We need to spend our money better. This will create fiscal space, and we need to engage on debt relief conversations as civil society advocates. But and we need to understand concepts such as UHC, progressive universalism, and we need to engage with public finance management, the budget cycle, understand its calendar. So there's a lot of self-learning that we need to do to be able to engage meaningfully with these questions of health financing and co-financing and transition away from aid. But really what I've been trying to say here is be careful, because all of these solutions, whether it's taxation, efficiency, debt, etc., all of these solutions are complex, they take time, and they can't all be put in place to the satisfactory levels that are expected from donors within 3 years, which I think is some of the timelines that we're hearing will be needed to be able to transition away from aid. There are some benchmarks that as civil society we can use in our advocacy, some globally recognized benchmark. For example, we know that if we're serious about UHC, we need to spend a minimum of $60 per person per year. And at the moment, less than a third of countries, low-income countries, actually spend that. Some countries spend $3 per person per year, particularly on primary healthcare. So yes, this is a target that we can use. We can use the Abuja target of 15% of national budgets need to be allocated to health. Although from experience, this target is less and less used because ministries of finance say, well, 15% here, 25% there. I end up in 200% of my budget being pre-allocated. That's not the way it works. Another benchmark that we hear a lot about that is being used is that you need at least 5% of GDP to be allocated to health. And in low-income countries, for example, we are at about 2%. We know that we need less than 20% of total health spending coming from out of pocket. We know that less than 2% of health, 10% of households need to spend less. Catastrophic health expenditure is bad, and we need to step away from it. Sorry, I've lost my train of thought on that one. And finally, we know that the concept of progressive universalism is well accepted, and it is something that we can rely upon when we talk about UHC and progressing towards health financing, better health financing. So, yes, push for more domestic resource mobilization. Absolutely, it is the responsibility of governments. But make sure that as civil society, you understand the evidence, you understand the budget cycle, you understand what is progressive universalism, what is equitable or inequitable, and you understand first and foremost what is realistic. And that you push back when suggestions of rapid transitions are put on the table. With that, I will stop. I thank you very much for your attention. I think that we now have time for questions, but I will hand over to the facilitator for that. And then we'll have a presentation on specifically what all this means for civil society.
Hello, Nuria, and hi everyone. Do we have any questions for Nuria? Because before we move on to hear about opportunities for engagement from colleagues from MSF, you can raise your hand or you can put them in the chat. I think everyone is appreciating the presentation. No one has any questions or comments. So yeah, that's terrible. And you just record you and you can retire. All right, please, Laura, go ahead.
Oh, I couldn't unmute myself. Thank you, Quentin, and thank you so much, Nuria, for this great presentation. I'll put my camera very briefly. No, this was like so clear, and you managed to like connect so many different things we all advocating for. I think I just have like a comment rather than a question, but as also like I see a lot of advocates here that we know that are also like very involved in universal health coverage and health financing, health system strengthening. For immediate action, also like we had like two different campaigns for UHC Day, focusing on out-of-pocket expenditure and to limit that to progress towards universal health coverage. We'll have a third campaign also this year with like key messages also very linked to Nuria presentation and the work done here. So I'll put the link in the chat for eventual advocacy statements or templates, key messages that are very linked to that. Thank you again, Nuria. That was excellent.
Thanks a lot. Thanks a lot, Laura. Do we have any other questions or comments from anyone? Otherwise, we'll be passing on the mic. All right. Well, Nuria, if you want to quickly answer or add to Laura, and then I'll give the floor to Tess.
I didn't think there was a question. I thought it was just a comment.
Agreed. Right? Just wanted to give you a chance.
No.
Tess, floor is yours.
Okay, I'll share the slides again.
Perfect. Thanks, Nuria. Just to say again, thank you so much to Nuria for this, because it's really using her expertise, and I've also learned a lot. Just briefly, so I'm with MSF, and I link all of MSF with the Global Fund, so also part of the one of the delegations that sits on the board. And welcome any feedback or questions on this, please do ask. I want to just say, just to start with, that as is already said and been reinforced, a lot of this you already know, but we're very aware, like as MSF, for example, in projects, of the gap in knowledge sometimes of where we sit or our understanding of health financing and what's being proposed, which is why we initiated this webinar, because we can see that there is a need to link this up, given what the proposals are taking place and what donors specifically are pushing for in terms of savings. Okay, so the essential role of civil society in the grant cycle 8 dialogue. You know a lot of this. I really feel like a lot of this we have, but sometimes it's quite useful to have it all together so we can see it all. I think crucially here, it's about making sure that we present and keep on the table the added value of what CSOs offer that others can't, like those insights in terms of how the national statistics mask inequalities among specific regions and vulnerable groups. And I'm thinking especially in the Asian countries at the moment that are in transition, and looking at, okay, the overall, but the importance of making sure that we pull out those statistics of the vulnerable groups that might not be so obvious when you're looking at a national statistic approach. I think also just crucially here on the community contributions, the invisible but not critical. The importance that Nuria also mentioned, but like really to reinforce and make sure that we are holding governments and the Global Fund accountable against any international agreed benchmarks. Does this make sense for what we see in the country, or is it completely disconnected and unrealistic and is not going to help, in fact, might even do harm in the long term in terms of the needs that we see for the populations that we work for? Next slide, please. Okay, again, Nuria really emphasized it, but the scale and the pace of the transition. So to be frank with MSF, so we're in 70 plus countries. Most of them come under the COE policy of the Global Fund, the Challenging Operation Environments, but we have a few that are transitioning, like in Latin America, for example, transitioning in Grant Cycle 8. The key question for us, and that we're talking about in MSF with projects, is, does this make sense in terms of the pace of transition? Is it realistic? From the evidence that we have in MSF projects, is what is being proposed realistic in terms of timing, or actually will it do harm? And do we have the data to illustrate this and push back a little bit on it? I think also the over-optimistic viewpoint, this DRM will solve this solution in terms of the withdrawal of donors and the funding available, is really important to push back against. We might be hearing a lot of, okay, so this is the way forward and we have to just accept the DRM requirements that are being placed and put in grants, for example. But actually for MSF or for where we sit, it's like, hang on a second, no, we will question it and we will push back if it doesn't make sense for what we see. The UQD, in terms of the grants, we know that obviously we have the allocation letters. We have potentially what countries will have in their grants, but it's always that extra caveat, which is super important with the Global Fund, of there may be additional funding or funds unspent that are available. And if we put at the forefront our pushback, this is realistic, these are the gaps that we see at the beginning, if money comes available, we have those points at hand to be able to present and make sure that they can be put forward to use those funding and those amounts. Again, just to say, out-of-pocket payments, definitely not DRM, needs to be pushed back immediately if it ever comes on the table, and be very clear on the communications of this, because we know that this will hit heavily, especially those less well-off, those more vulnerable groups that might not be captured in the data immediately for the Ministry of Health or for central governments. And then in terms of budget transparency and execution, hands up, as I said, as MSF, it's not our forte, shall we say, our comfort zone, always to understand what's going on in the country in terms of the national budget to health and the national budget cycle. So what Noria just covered is super useful for MSF in country. But we now know, and we now can see how important it is to really understand what is being proposed in your country, the implications of this, and how much of that has been allocated to health. And does that make sense from what we're seeing, or actually is there capacity to push back and to highlight the needs and to show that actually it's not being met and there is space to do this? Next slide, please. Okay, so in terms of the debt and fiscal space, so Noria highlighted a few of the benchmarks that we can use, that we can put forward in terms of what's been proposed and to refer to internationally. I think in terms of making sure, as I say, like previously, that we're familiar with the national budgets that have been proposed, what's there in the country, and request these plans from MOH, like keep on the agenda, make sure that we are kept on the table and in the communication in terms of what's planned and proposed, and we know what's going on. And request that money is allocated to specific interventions that improve access and quality of care and health outcomes. Just on like the point Noria made around pooling and how the Global Fund will, have in some instances had very vertical approaches. To pick up on Noria's point, yes, definitely the case that it's good to pool the funding, but also as civil society, especially in certain countries where we work, there are very vulnerable groups. And those that funding that is going towards them needs to be protected. We need to put that at the heart. Those are the populations that are most at risk. Those are the populations that will be missed if we do not make sure that that funding is kept and protected for them. And then community contributions. So what we see in terms of HIV with lenacapavir, for example, the potential for the TB vaccinations, even the malaria vaccination, what we see is the key services, the innovation, so forth. What is critical in terms of if we are going to really look at addressing these three diseases and really working towards those 2030 targets, for example, the funding needs to be there up front to do this. And it is the CSOs, the community, the people at the heart of this that really provide the insight and can provide the insight and the monitoring and the care that's needed in terms of the response for these diseases. Just a last note here on integration. We know, obviously, that it's a real strategy in terms of moving forward for the Global Fund and the grants, but we need to be cautious, firstly, of what that means for certain groups and are they being included in terms of that integration, and also in terms of what are they integrating into, like our understanding of the Ministry of Health, of the healthcare system. Does it make sense? Or will they be lost once that integration is encouraged or reinforced? Next slide, please. Okay, so MSF, just quickly, and I'm wary of time, so do pull me up, Quentin, if I'm going over, but the fragile and conflict affected states, for MSF, and it will be on the next slide as well, we see an increase in terms of the amount of emergencies and conflicts that we see. The talk or the proposal of co-financing requirements does not make sense in these states. But what we need to do is make sure that that argument and the data behind it is presented. Why it doesn't make sense? Because we see repeated conflicts, they're emergency, they need flexible and adaptable responses. It can't just be, oh, okay, we need to now look at this country stepping up when the healthcare system is not stable enough to provide for its population because of a conflict taking place, because there's an environmental emergency. It also means that in terms of stigmatized groups and vulnerable groups, they're even more vulnerable in terms of what they're experiencing in their country and the capacity for them to be lost in the analysis and their needs. And the ability and willingness, depending on what's taking place in the country, might not always be fair in terms of the approach or who is of priority for that particular government. Next slide, please. So just to quickly, as you all know, and I guess it depends on which region you're sitting in, but definitely for certain regions and for MSF in particular, the CSO, the challenging operating environments, it's already 1/3 of the Global Fund portfolio. Now with the transition, it will be even heavier. The CEO, portfolio will be even greater in terms of the Global Fund investment. And it's just to make this point and reinforce this need and the complexity in terms of response and the pushback against co-financing in these contexts. Next slide, please. So DRM, domestic resource mobilization, co-financing and so forth is really tricky, if not feasible, realistic in these countries. And it's important to push back on. It's important to pull out, as I say, like some of the funding actually, or some of the issues and topics that we see, they might not get funded immediately, but it might go through additional fundings that come up, and we have those to hand, those needs to hand to highlight when additional funding does come up. The CSO, I think, crucially, and what I would say about these contexts is that CSOs, community-based organizations, provide real insights into the reality of what we're talking about, especially in these kind of contexts that others do not have. We work with the Global Fund often. They often don't go to Sudan in person, the Geneva team, because they can't, because of safety and so forth. So they're reliant on CSOs. They're reliant on community-based organizations, civil society, to really have an understanding of what the needs are. And if they don't have that, they can't recognize, they can't allocate funding for it and make sure that that fund is going towards what it's needed for, but also to push back on the, as I say, the co-financing requirements, DRM, etc. Next slide, please. Okay, so in terms of transition, so I think we have a few countries here, and again, really would welcome your feedback and insights on this as well, and questions. But from an overall analysis of where transition is taking place for GC8 and the pressures of co-financing and DRM requirements, the portfolio is heavily weighted for GC8 for HIV, TB response of those countries that are transitioning. The TB response, as we know, is heavily reliant on the Global Fund. So what do these cuts mean for these transition countries? Are they realistic? And does it mean that actually these targets that have been set out for HIV and TB will be met? Are they in danger if, for example, there's a sharp cliff in funding shortfall in 3 years, or when the US MOUs come into play, for example, or if they come into play and then the US stops funding in a few years? What does this mean? And does it then put into jeopardy what we've all been working for over the last 20 years? And is there something we can evidence, show as civil society to highlight the danger of doing this and to really make sure that that argument is on the table when ministries of finance, ministries of health and so forth are making their commitments to DRM. I will go to the next slide. Yeah, so just like there are certain topics, for example, when they talk about innovative products or availability and so forth and transition, lenacapavir, for example, for HIV, the availability of lenacapavir for HIV in the Global Fund portfolio makes sense, but for countries that might be transitioning in GC8 and classed as more middle-income countries, their availability to lenacapavir and the price that's being offered is not there. It's not equitable. And again, that gap in terms of the availability of these innovative products for very vulnerable key populations that might be more obscure middle-income countries or countries that are now going through transition need to be kept on the table, on the agenda, so they can have access to these very innovative products. And this is kept in mind. Okay, that's the list of some of the countries that don't have access to lenacapavir. And then lastly, just on the key populations and vulnerable groups, I think that the audience here, yourselves, you know way better in terms of these specific needs and groups that are very vulnerable in terms of the three diseases: stigma and discrimination, social and economic marginalization, and so forth. These points, they have to be kept on the top table. I think that when we, as I said, for MSF, when we're in country, we're not au fait and we're not, well practiced always at engaging with the Ministry of Finance, of understanding what we're talking about when we're talking about health financing. But we're recognizing more and more and more we need to understand, and we need to bring these points that we see on the slide here in terms of our expertise and insight that you all have as well from your organizations, to make sure that this is understood. Just as we're making the effort to understand health financing, that they're making the effort to really understand the needs of why the money is needed, where the money is needed to actually achieve what we're all meant to be achieving, is kept on the table and not dismissed. And that integration in terms of dialogue, communication between the two groups is really there. I think that might be the last slide. Okay, so here's some key terms and definitions for your reference. I think we will be sharing the slides and so forth, so you can follow it up as well. But really welcome your points and feedback and comments on this, because as I say, we really see a disconnect in terms of a gap of making sure that CSOs are kept in the dialogue when it comes to this co-financing, DRM and so forth agenda, and that what we see is accounted for. Thank you.
Thanks a lot, Tess. So first, opening the floor for any questions or remarks. And thanks for a very clear presentation. I note a question for Nuria that's been partly addressed or completely addressed, I'm not sure if I meant, in the chat, just in case either Tess or Nuria, you will jump in while everyone gets a chance to raise their hands to ask any other questions.
Can I just say that I think it would be really useful that Nuria still answers the question, because she has a lot of experience on what speaks to governments. She has been working with a lot of governments and ministries of health.
So the question is, which benchmark is the most useful? That's a very good question. I can tell you which one is not useful. Which one ministries of finance always push back on is the 15%, sadly, of the Abuja Declaration. It's just doesn't resonate with ministries of finance. The way that we've managed to advocate effectively is not so much by using the $60 minimum per person per year, because then countries say, yeah, well, $60 is a global benchmark, so it's not relevant to my country. But it has been by doing costing exercises of the benefit package that we have in mind and demonstrate how much it would actually cost to provide a basic package of services that integrates communicable and non-communicable diseases, and then show the gap between the need and the resources that are available. That has been the most useful way of advocating. But if you don't have the resources nor the data to be able to do the costing of the benefit package and show the gap, then the next best thing is a relative benchmark, is the 5% of GDP. Because an actual number, $60, sometimes doesn't work, but 5% of GDP, when you compare it with all the countries in the region, and you show how far your country is compared to others, then it tends to be the one that receives the best response. No.
Thanks a lot, Nuria.
Yeah, and maybe the percentage to primary healthcare might be also useful.
Yeah, so primary healthcare, absolutely. Thanks for highlighting that. Primary healthcare has been identified as a cornerstone to progress towards universal health coverage. Everyone understands this. And saying that you need a minimum of 50% of resources going to primary healthcare is something that you can use. The problem, though, in many countries is that what primary healthcare is not very well defined. The tracking of resources all the way to primary healthcare tends to be very weak. So for you to demonstrate whether or not a certain percentage is allocated to primary healthcare is complicated, but there's a lot of efforts globally by organizations such as the GFF, for which, by the way, I work as well. They do these resource mapping and expenditure tracking exercises that really help in understanding how much does go to primary healthcare. But the first thing would be define what primary healthcare is in your country, and then advocate for a large proportion of resources, up to 50% at least, to be allocated to PHC. There's difficulties with giving priority to primary healthcare because politically, primary healthcare is much less visible than hospitals. So governments have a tendency to want to build new hospitals in urban areas where those who have resources tend to reside, and therefore will vote for that particular government if they see a brand new hospital being built. So primary healthcare is very important for UHC, but is often not prioritized, and you can indeed use that 50% benchmark.
Thanks a lot, Nuria. And Rosemary, do you want to ask a question?
No, thank you. I just wanted to add a quick addition to the presentation and to the explainer, just to say that in the presentation, there are many things that I appreciated, and I know many colleagues did appreciate. For example, saying that 15% Abuja, 5% of GDP, 86 per capita are all great targets. But then there is also a movement towards saying that it's not just about the numbers, because even if you had 15%, there would still be so many gaps. And so the current framework that the African Union member states are using around domestic financing is the Africa Leadership Meeting on Investing in Health, which pretty much acknowledges all those targets, but then also says we need to combine that with some kind of qualitative targets. And the qualitative targets include being able to track or to have conversations around, is the money being invested additional? Or are we just substituting the money that is coming in and replacing that? But are we actually incrementally making additional resources? And then number two is to say, are we getting better outcomes out of the investments? And that's important because going back to the slide around purchasing, like what is being purchased, what are we paying for? A lot of times, what these budgets are purchasing are activities and inputs. So we are purchasing X number of injections, we are purchasing X number of condoms, and so on and so forth. And I think the more progressive direction is to actually pay for outcomes, like what are we getting out of that? And then the other element is the equity, which is aligned to what you are saying in terms of who actually is benefiting from the investments. And the last one is governance. How is resource allocation being governed? How is implementation being governed, which includes also decisions being made by an inclusive governance kind of structure, which means impacted communities and civil society, are they part of decision making around prioritization, around what is purchased, around what is invested? So just wanted to just say how aligned, and to also just reflect on the latest regional framework for investing in health. Thanks.
Thanks a lot, Rosemary. I think you've made a really critical point, and you emphasize the importance of it isn't just about more money for health, but it's also more health for the money. That's something that we've been talking about for 16 years now, since the 2010 WHO report. It is about, we have scarce resources. How can we best use them? Absolutely. So I completely agree with everything you say. And Bashir, I see your question around allocating health taxes to health. So the evidence, aside from the fact that the amount of resources that health taxes raise isn't enormous, but it is at least something. The difficulty we see is in the fungibility of funds, i.e., okay, you're raising an extra $1 million from tobacco taxes. How do we know that these resources are actually going to be additional for health? Because governments of ministries of finance tend to not like the earmarking or hypothecation of taxes, i.e., you saying this tax on tobacco needs to be allocated to health. They don't tend to like that. They like to have control over their overall budget. But what you see in many countries is that, okay, additional resources are raised on the one hand, but on the other hand, resources are taken from somewhere else. So is it really additional money that is being allocated through these health taxes, or is it just a shifting around of the budget? So there's quite a lot of literature on that, including a systematic review that I did a couple of years ago, that shows that it is a good entry point for discussions with ministries of finance, certainly. But it becomes difficult the moment we start talking to ministries of finance about earmarking, and it becomes difficult when we start telling them that it has to be additional. But it does happen. I don't want to say that it doesn't, but it isn't just about winning the battle of an additional health tax. It's also about winning the battle of that additional money being earmarked and being additional. And the earmarking is not necessary for it to be additional. You can let go on the earmarking as long as you say, as a result, we need more money for health, whether it comes from that tax or from the budget more broadly.
Thank you very much, Noya, and thank you very much, Bashir, for your question. I don't think I see any other hands up. Amanda, please, of course, go ahead.
Yeah, no, thanks so much, Nuria, for such a great presentation and overview. I really liked actually your systematic review on the taxes. I think it was just my question to see whether you're going to update that, because that was really an interesting paper, especially at the beginning of the experiences that we had with the funding cuts. But I'm curious to see if you're planning to update that, especially with the changes, to see what has changed since last year. I can update you that, for example, following conversations in Tanzania, the government is moving towards, really putting specific, sort of like earmarked resource for health following the cuts. Conversations have moved at a very advanced stage now, also in Zimbabwe, outside of the National AIDS Trust Fund. Even in Malawi, we now have the government, despite the limited fiscal space, there was a decision last year in the budget conversation, and it's going back to Parliament now, where they have allocated 2% of the taxes to health. But again, the ring fencing point, I get you and I hear you, that's a challenge. And I think what's now becoming problematic, and that's why I'm interested to see if you're going to update your paper, is to see how much of this rhetoric again is translating, because that was noted in your paper that it's more political mileage and like rhetoric. It doesn't necessarily translate into the money has actually gone to health, and that's where the problem is. And civil society and partners in a whole lot of different countries are now also engaging and working on the tracking of those commitments to did the money go and what has happened and where has the money gone and where is the impact at the primary health care facility level. So the conversations on taxes, on levies, on things, I really had found that paper really brilliant and very useful, and just checking to see if there's going to be like a very consolidated, systematic, robust, rigorous sort of like evidence paper next to what you produced, because I think that was really great. Thanks.
Thanks a lot, Amanda. That's not yet on my to-do list. I agree, it's an important question because things have moved a lot since that paper, but I'm sure it's not on my to-do list.
Oh, so now we're a lot of people. So I'm going to take Itai first, and Rosemary has a follow-up for you, Nuria, in the chat, and Laura as well. Itai?
Yes, thank you very much. Thanks a lot to the presenters for the very excellent presentation. Yes, my name is Itai Rusike, and I'm from Zimbabwe. As you're aware, Zimbabwe, I think, was one of the first countries to come up with a very innovative domestic health financing strategy in the form of the AIDS levy, or the National AIDS Trust Fund, popularly known as the AIDS levy. But I think the difference with the AIDS levy and the other earmarked health taxes is that it was set up through an act of parliament. So it is ring-fenced and protected. So as a result, it goes directly to the National AIDS Council, through the National AIDS Council, a trust fund. But we have also come up with other numerous, earmarked health taxes. We now have the health levy. This is from use of mobile phones, data, and 5 cents, from every purchase goes, towards the health levy. Initially, it was the earmarked towards the addressing, the challenges around cancer machines, and the perennial shortages of medicines in our hospitals. And then we now also have the sugar tax, from beverages. And we also have another one called also the fatty foods, the fast foods, where they are now taxing, when you buy the French fries, the pizza, and so forth. But unfortunately, if you compare with the AIDS levy and all these other numerous taxes, these other numerous taxes are not being ring-fenced, and they are not going to the Ministry of Health. There is a big challenge in terms of the Ministry of Health accessing that money. And that money is going to the consolidated revenue, fund, which then becomes even very difficult for us to track, how much has been collected and how much has been disbursed, even to the Ministry of Health. So sometimes, yes, as civil society, we advocate for these, innovative domestic health financing strategies. But at the end, you'll find the government is then using these taxes, as additional revenue, to go towards, the treasury. So it's the challenge that we are currently having in terms of even tracking, how much has been collected. If you ask the Minister of Finance, he'll give you a totally different figure. You ask the permanent secretary in the Ministry of Finance, he also gives you a totally different figure. But industry has been sharing in terms of how much they've paid, especially on sugar tax. And their figures are much, much higher, compared to the figures that we hear from the government, authorities. So the issue of earmarked taxes is always a tricky situation. But maybe if they'd used the same model with the AIDS levy, whereby it's ring-fenced and it goes to, the National AIDS Council.
Thanks, Itai. I hear you. I would say, though, that earmarking is not necessarily a good thing, because what if there isn't money anymore? What if the taxes that you collect are not sufficient to cover your needs? And it's important for a government that is benevolent and wants to take care of all its population, to have the ability to decide how to allocate resources. So I think to say earmarking is good per se, and not earmarking is bad, it requires nuance. Also, the problem with earmarking is that you end up creating pools that are different. So you contribute to fragmentation, and one pool will finance one thing, another pool will finance another thing. It's very difficult then to think about a person who gets affected by HIV, by TB, by a woman may get pregnant. It's more about making sure that we think about the whole person and the whole life stage of the person, and that there are resources to fund a basic primary benefit package. So I think I'm a bit more ambivalent about the strong advocacy for earmarking. I think we need to be cautious with it. But I know what Zimbabwe has done, and that's pretty amazing. Absolutely.
Thanks a lot, Noya. I see one last hand raised for Mit. Technically, you're co-organizer, so I don't even know if you need to raise your hand.
I wanted to add a bit on this earmarking for health. I think it could be also interesting to have not only just earmarking for the health sector, but to have for specific health interventions or that we know are contributing to better access, to better quality, etc. And especially, so I'm for the debt relief, for example, if there is debt for health swaps, it could be interesting to push for that. For example, I gave the example of Burundi yesterday or the day before, where there, from the previous debt relief, there is specific money that has gone to a pool with donors and with the World Bank to make sure that the financing of the free care for children under 5 could be realized. So that's one example. But also here in this case, we are having a bit more leverage, I would think, because we're discussing it in the cycle of the Global Fund, where there is a specific transition of domestic funding, co-financing that is demanded from the government. And there also we could insist a bit more on certain things that under the Global Fund funding before, there were specific interventions that were favored and funded, that the domestic funding will have to really replace that. Just a way of thinking a bit further. And the point of the accountability, of course, is very important. I think it's important that the civil society would also play a role in independent observations and reporting on what is happening with that money. Thanks.
If I may respond to that, Mit, I hear you, but in a country, you're going to have 10 different groups going to a Ministry of Finance, asking for that tax on tobacco to be allocated for this group and that group and that group. The taxes that exist in a country, there's not a million. These are the taxes. So there is really a danger, and I have heard ministries of finance say this so often. You all come with your fiscal space analysis or with your innovative financing mechanism calculations for your particular disease, and this 10 other people waiting outside are advocating for another disease or another group. So I think there is a danger in fragmenting too much. And my recommendation, and I work, for example, in Sierra Leone with Global Fund and others, my recommendation, if we want to ensure that there is protection of those groups, would be to integrate the discussions of the Global Fund with national health reforms and integrate the diseases in the basic benefit package. The moment that you integrate the diseases in the benefit package, then there is real transition towards these diseases being understood and owned by the government as being their responsibility. So I would come at it from a different angle.
Yeah, but I think we can include health interventions for specific groups. And the example of the free care for the children under 5 it's not for a specific disease. Huh?
Yeah, absolutely.
Or for key population. So it helps, this moves towards more equity and more access that could be useful instead of just saying it goes into health, make it go to better outcomes, like Rosemary was saying.
Yes, do you want to jump in?
Yeah, just quickly, just to say, I think also with the key, like civil society, full stop, like this definition of health. I come from a public health background. I'm not a medical, technical person. And I think that in terms of the Global Fund and the grants moving forward and the proposals of like co-financing and so forth, it's really important that civil society keep Global Fund focus on supporting civil society, this kind of broader scope of who represents the people impacted by the 3 diseases on the table, and that there is money allocated for that, for things like this, for example, like capacity building about what co-financing means, what DRM means, make sure that we as advocates also make sure that the Global Fund is kept accountable when they're engaging with countries on the ground to keep them on the table, because it's very hard in countries sometimes to engage with Ministry of Health and so forth in these discussions of civil society. We can also use the Global Fund to push for this as well. So just to say that money, disease specific, health specific in a strict sense, sure. But I think actually the people representing the 3 diseases are crucial to this, and resources and money is needed for this.
Thank you, Des. And yeah, I mean, I'm professionally obligated to strongly agree on the Global Fund side of things. We have a few minutes left. I think Rachel had closing remarks that she wanted to make, but I'll give the floor back to Garthi, I think. Oh, Garthi
Sorry.
or
Hi,
Rachel?
Quentin.
Yes.
Yes, apologies. Yeah, thank you so much. This has been a really rich and insightful discussion, and I think we have learned a lot. Thank you so much, and we will continue this discussion. GFAN Africa, GFAN Asia Pacific, GFAN will continue to hold these kinds of spaces where we can come together and discuss. So thank you to the MSF team, Tess, Nuria, Mit, thank you so much for being generous with your knowledge, being generous with your insights, and speaking to us so frankly. And thank you to all the participants who asked such great questions and joined us on short notice.